wanted to talk about precision medicine in the. I am speaking down here myself. I'm going to talk about precision medicine and rhinitis. And as many of you may know, I have many homes, one in Aberdeen, where my academic chair is, Norfolk, my home in the UK, and Singapore, where my main home is. Here's my disclosures. And I want to talk to this afternoon and this evening to you about thinking about precision medicine in rhinitis. And I guess guidelines have been out there now since 2001, when the ARIA guidelines were first published. And I think they have been transformational in setting the scene for how we should manage rhinitis. And this was the initial guideline that was published at the very beginning in experimental allergy. And I think we've come on quite a way from there, but I just wanted to think a bit about how successful that has been. You know, I think we've had the guidelines, but patients are very dissatisfied with their therapy. Patients continue to experience symptoms. And what was being very striking is many patients in surveys are taking multiple therapies and that they look for better and faster relief. And we're not achieving that for them. The guidelines themselves have identified limitations right at the very beginning. Of high quality evidence and the lack of systematic reviews for many of the questions that we wanted to answer. And there's certainly a scarcity of high quality evidence supporting decisions about treatment. And there's also been primary and secondary clinical research. And if we think about the burden for our patients, rhinitis seems to become more severe. What we see is a shift from mild disease to more moderate and severe disease. With 67% of people being moderate or severe, and 42% having moderate, persistent disease. And then we've also had Jean Bousquet's concept of SCUAD, severe chronic upper airway disease. It seems to be about 30% of allergic rhinitis patients. And what we've seen in line with that is an awful lot of systemic problems and productivity impairment for our patients. And what we've also seen is that it has a negative impact on many patient activity. And also with a big impact on sleep and emotional well-being. And then alongside that is the whole consequence of comorbidities. And what we've also seen, and this is some of our early data, basically showing patients with asthma and rhinitis are more likely to have poor control of their asthma. So rhinitis is not just on its own, so we have also the whole impact of the comorbidities. And this is a very recent paper of ours where we've actually shown that people with rhinitis are 1.5 times more likely to have poor control of their asthma. And further data showing that adequate treatment of rhinitis improves asthma control. So the use of nasal steroids on top of asthma treatment improves asthma control, and also the use of leukotriene antagonists improving asthma control. And then, in addition to that, we find many patients are not receiving adequate therapy. And furthermore, is many of our patients are on multiple therapies. So what we see is that many patients are requiring, on top of their intranasal steroids, antihistamines, and unproven additional therapy. And many patients require ocular therapy, systemic steroids, and leukotriene antagonists. So many patients not achieving control and needing multiple prescriptions. And then I think this is very important data from Australia. So there's been a shift in many countries towards using over-the-counter medicines and the de-medicalization of rhinitis. And so what we've seen in Australia, which is the first country to actually insist that most therapies for rhinitis only be available over the counter through pharmacies, is that the basic main therapy in Australia now is antihistamines. And during the hay fever season, what we see is actually virtually nobody getting intranasal corticosteroids, and most people are receiving antihistamines. So doctors are not prescribing the treatments that work. So I wanted to think about how it could be done better. And I think this is the most important part of what's going on in rhinitis today. And I'm very excited about the MACVIA ARIA app that many of us have been involved in developing, which actually collates key information on patients with their rhinitis. And it has an algorithm using the visual analog scale. And I think this algorithm, I think, is very much the way forward as we think about personalized medicine. And it's based on the visual analog scale. And its basic principle, it says, if your visual analog scale is above a certain score, if you're above 5 out of 10, you need more specialist assessment or increase of therapy, depending on what treatment that you're currently on. So this sort of basically says that if you're mild in terms of your symptoms, you can manage with simple therapies like an antihistamine. If, however, it's more severe than that, you should be stepped up in treatment, or if you're already stepped up, referral. And I think this is the key to the future management. And so we get a rating of people's symptom scores, and they can also see their symptoms over time. And so we actually are now in Grampian in Scotland, where my academic chair is. We're actually testing this in pharmacies as a way to empower pharmacists to manage their patients. So we have permission from the Scottish Government for pharmacists to be able to prescribe all therapies: antihistamines, nasal steroids, combinations of nasal steroids and nasal antihistamines. So they can prescribe right through the range of therapies. And our outcomes are going to be uptake and use of the app, and the appropriate use of both nasal steroids and combination nasal steroids and nasal antihistamines in the management of patients' rhinitis. And we'll get an evaluation by patients and pharmacists questionnaires to understand whether that's effective in patients' treatment. So I think the time is right now that we have to better manage patients with rhinitis. And I think it's also appropriate that we think about the new ARIA guidelines in light of this. So we're going to be helping patients to better make their decisions about their rhinitis. So I think to conclude, current allergic rhinitis therapies have not been adequate in terms of achieving control for our patients. We have newer effective regimes. We also have new pathways that I think can help patients to better manage their disease. Thank you very much for listening, and I'm open for questions.